This conference will now be recorded.
Great. So I want to welcome commissioners and members of the public. This meeting is another remote-only commission meeting. Is Dr. Brumbaut on the phone yet? On the line yet?
Yes, I am.
Welcome. So I want to introduce and welcome new Commissioner Trupti Brumbaut from the RAND Corporation. Dr. Brumbaut, prior to joining RAM, served with the Department of Defense for 20 years. She's held senior leadership positions under the Secretary of the Navy, and research organizations, the National Interagency Confederation for Biological Research at Dietrich. Dr. Brumbaut has served as an adjunct professor at the Uniformed Service University of Health Sciences in Bethesda, where she earned a PhD in emerging infectious disease. Welcome, Dr. Brumbaut. We look forward to meeting you, hopefully in person someday soon.
Yes, sir. Thank you for the kind introduction.
Given that this is a remote-only meeting, additional ground rules will apply. I'll begin this meeting with a roll call of commissioners. During the meeting, I'll ask that people speak and identify themselves. That way, commissioners and members of the public will know who's talking and have the same knowledge as if the meeting were held in room 100. We're using the GoToMeeting app for the second time today. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless I recognize you. Due to the possibility of background noise, I ask the commissioners and others mute their phones when they're not speaking. And I note that we're getting a little bit of background noise now, so if folks could check and make sure that they're muted if they're not speaking right now, that would be helpful. In future remote-only meetings, we'll post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to dial into the meeting by posting that information on the Commission website homepage and our various social media channels. If there are no questions, I will now call the roll. Commissioner Bandari, I heard you before. You're still there?
Yes, please. Thank you.
Commissioner Boyer. Cassie, are you there? But we don't hear you yet. Commissioner Boyle, I heard you.
Yes, I'm here.
Commissioner Brumbaut, I just spoke to.
Yes, sir. Still here.
Commissioner Dorden, I saw
Here.
you. I can see you. Yep. Commissioner McCarthy.
Present, I'm here.
Welcome. Commissioner Metz. I did not see him, and I think he may have indicated that he wasn't able to attend. Commissioner O'Connor, I heard before. You're still there?
Still here.
Commissioner O'Grady, still there?
Here.
Commissioner Reimer. I see initials there that match, but I don't hear anything. All right, Commissioner Reimer, if you're there, we can't hear you. Commissioner Sargent, I heard you and saw you before. Commissioner Thomas. Dr. Thomas, are you there?
Hi, this is Martha Reimer. Can you guys hear me?
We can hear you now, Martha. Thank you.
Thank you.
Stephen Thomas, are you there? I do not see his initials. And Commissioner Wang.
Commissioner Wang's here, Chairman Pollock, and I also want to say I was at the last meeting too, but I'm not on the minutes.
Okay. So noted.
Commissioner Metz, I was able to make sense.
Somebody doesn't. I see Commissioner Thomas has arrived. Commissioner Thomas, can you hear me?
This is Commissioner Metz. Can you hear me, Andy?
Welcome. Yes, I can hear you now.
Thank you.
All right. Commissioner Thomas, can you hear me yet?
I can hear you loud and clear, reporting for duty.
Welcome, sir. Have any other commissioners joined the call? I believe we have a quorum at this point. So agenda item number 1 is approval of the minutes. Included in your packets are copies of the minutes from the July 16th commission meeting that took place by public teleconference. I have one correction to those minutes to note that Commissioner Wang was present and was not noted on the minutes. Do I have any other comments on the minutes?
Chair, could I also make the same correction? This is Commissioner McCarthy. I was on the last meeting, but I'm not also on the minutes.
Very good. Any other corrections? All right, now I'll entertain a motion to approve the minutes as with the proposed amendments from the July 16, 2020 Commission public meeting that took place by teleconference. Do I have a motion to approve?
So moved.
Commissioner Sargent.
Marsh.
Commissioner Sargent, and I think that was Commissioner Reimer was second.
Marcia Boyle was.
Commissioner Boyle, sorry.
Mhm.
Any, all in favor?
Aye.
Aye.
Hearing none. Before we begin agenda item number 2, I just want to note that this is an August meeting of the commission, and that is out of our regular order. We typically do not meet in August. I just want to thank the staff for a tremendous amount of work in putting together an extra meeting during the year. We felt that this was necessary in order to get to clear some work off the table and allow some projects to move forward. And I think it will help keep us on target from a temporal standpoint throughout the year. I do recognize that this is an extra commissioners for attending the meeting, so and preparing for the meeting. So I want to offer my thanks. And if they're not speaking, if they could mute, we're getting quite a bit of shuffling paper background. The agenda item number 2 is update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates?
This is Commissioner Sargent. I don't have a question so much as just maybe a comment or suggestion. Since we have the report at the end of the day about redoing the site, I was looking at the statistics, and it would be helpful to me where we're reporting site visits to just see like the monthly changes rather than like each day. I don't have a vision of whether there are more people than in the past using the site, or I would just encourage maybe the staff to think about how could we get some longitudinal information about whether site use is increasing or decreasing, as opposed to maybe the specificity of which day it's a particular level.
Thank you.
We'll work on that. It's Teresa.
Thank you.
Other comments or questions? Does the executive director have any updates? Ben?
Thank you, Chairman. First off, on behalf of the staff, I want to also welcome Commissioner Brumback. We're looking forward to her participation on the commission. This is the first August meeting of the Healthcare Commission ever. Dr. Pollack somewhat stole the glory of informing you all of that, but we really do appreciate the staff taking an additional meeting. I know that we always advise new commissioners when they begin that there is no August meeting, not so in this unusual time. I have just a few updates. August, although it's no meeting month, is typically a month in which we get ready for the legislative session. We have had several briefings with commissioners over the summer. As you, most of you know, any legislative proposals that the Healthcare Commission puts forward has to be run through the review process operated by the Governor's Legislative Policy Office. So we do not make public any legislative plans. Commissioners that wish to have an update or did not receive an update should contact Megan Renfrew, who will be pleased to give you an update and a status report on where things stand. On as well as legislative proposals, we are moving forward with our 2022 budget proposal. That, of course, shaped by obvious concerns about just what will be the status of the state budget in 2022, given the pandemic. The commission will, of course, be somewhat treated somewhat different as we're user fee funded. But we will be mindful of directives that are coming down from the Department of Budget Management as we prepare our proposal. As I told commissioners in July, the Department of Budget Management generously allowed the commission to move forward to fill a number of vacancies that existed before the pandemic broke. And we are now at the conclusion of the recruitment phase of that. We are recruiting in the Centers for Health Facilities Planning and Development a methodologist and a program manager to assist Eileen Fleck. In the Center for Quality Measurement and Reporting, we are going to be adding a program manager. And in the Centers for Health Information Technology, David Sharps will be adding 2 program managers. One is a contractual position that will that would not have necessarily the same broad guarantees of a position long-term as a permanent position. But we have been able to use those slots very effectively and have made very strategic and important hires over the last 6 months to get people on board that can help us right away. After the July meeting, DBM also approved us to fill a position that will be assisting Mahi Higatu in the Ken's center, focusing on expanding use of the Where the Cost effort, as well as handling some of our expanding data release activities. Just a brief note on other government activities that we either work closely with or support. The Health Benefit Exchange has now expanded the special enrollment period for individuals that would seek to enroll in a private health plan through the end of the year. So that has meant that beginning in March, extended once through July, and now extending through the end of the year. Individuals who have lost coverage or seek to enroll in coverage through the individual market for the first time can obtain insurance. As most of you know, Medicaid enrollment is open year-round, and that would continue to be eligible for qualified individuals. We also have 2 relationships with organizations that are not directly part of the Healthcare Commission. The first is the Maryland Primary Care Program that we support technically through our Center for Health Information Technology and Advanced Care Delivery. We expect to be asked by Secretary Neal to provide some funding for that program in 2022. As it's an important program, a key component of the Maryland total cost of care effort, and funding that is, I believe, necessary to keep that program moving forward. Secondly, the commission was asked a year and a half ago to assist in the establishment of the Prescription Drug Monitoring Board. The legislation to fund that board was passed in the 2020 session of the legislature. We don't know what the status of that piece of legislation is. It potentially would be considered for a legislative override at the start of the 2021 session. But in the meantime, we will continue to be providing support, both from the standpoint of staffing, support for their recruitment efforts, as well as a limited amount of funding to sustain the 1 employee that currently supports the board. More on that as we move forward, but we would anticipate that the funding on this important organization would be resolved one way or another in 2021. That concludes my update, and happy to take any questions.
Any questions for Ben?
Hi, this is Commissioner Boyle. Ben, I just wondered if you could comment on the nursing home facilities inspections, what's going on in terms of, improved safety, et cetera?
So earlier this month, there was a communication delivered by CMS Administrator Seema Verna to officials here in Maryland, pointing out that the Maryland Office of Healthcare Quality was lagging behind in conducting inspections that CMS had directed all states to conduct. There is some debate at that point whether it was only about 50% had been completed. The state maintains that it was actually closer to 75%. I learned yesterday on Tuesday that the Office of Healthcare Quality is now up to date with all of the required inspections mandated by CMS. Like other parts of the country, there are significant challenges with nursing home care given the pandemic, and I think this is going to be an ongoing challenge until a vaccine is found. The state has put significant resources, both from the standpoint of state personnel and National Guard personnel, into supporting the nursing homes. The Maryland Hospital Association, working with its members, has provided backstop support when there are significant outbreaks, and we can monitor that. But I think the broader questions are just as we think about post-acute in a post-pandemic world, how is the delivery of these services going to evolve? I don't know if Commissioner Metz has any comments. Certainly, facilities in Western Maryland and his facility included in that has done particularly well, but he might have some perspective he'd care to add at this point. He may be on mute or stepped away. Commissioner Boyle, does that answer your question?
Yeah, that's helpful. Thank you.
Very good. Are there other questions for Ben? Mute their phones on background noise. From before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any item, they should inform the chair. Since this is a remote meeting and a commissioner cannot move to the small conference room, commissioners who are recused should remain silent and mute their lines. We'll move on to agenda item number 3, action item, certificate of need for Greater Baltimore Medical Center. A capital expenditure of $108.2 million for a building addition that replaces and adds bed capacity. GBMC is applying for a CON to add 2 30-bed nursing units in a new patient tower to replace patient rooms that are small, outdated, and not compliant with the guidelines of the Facility Guidelines Institute. The project is part of GBMC's long-term plan to modernize its inpatient units, most of which are more than 50 years old. The project involves new construction and renovation. Program manager and CON analyst Jean Marie Gowell will present the staff recommendation. Ms. Gowell, please proceed.
Good afternoon, Chairman Pollack and Commissioners. Greater Baltimore Medical Center Healthcare, Inc. is the parent company of Acute Care General Hospital, GBMC, Inc., or GBMC in Baltimore, Maryland. The hospital is licensed for 257 acute care and 27 comprehensive care beds. The hospital is one of 6 subsidiaries, which also includes, among others, hospices, a nonprofit foundation, and physician practices. This CON application seeks to modernize the hospital facility in order to provide new private inpatient rooms and upgrade them to meet the current FGI guidelines. The current rooms are substandard in size and do not accommodate modern clinical needs. Current rooms are also a safety concern as they do not provide enough clearance around the bed or have close proximity to hand washing sinks. In addition, the rooms are a cause of patient dissatisfaction. This proposal includes a 3-story expansion located in the front of the existing main lobby between the 2 existing wings. This expansion will create a new space for 60 beds to be relocated from existing units. The new hospital will also house family and staff support spaces. The vacated space may be renovated for other future projects as GBMC executes its facility master plan over time. The project will consist of 106,083 square feet of new construction and 11,587 square feet of renovation. The total cost of this project is $108 million. The project will be funded with $70 million in authorized bonds, $30 million in philanthropy, $6.5 million in cash reserves, and the remainder in interest income from bond proceeds. A comparison of the project's estimated construction costs using the methodology provided by the MBS benchmark showed construction costs that exceeded the standard. Thus, the commission included a condition to ensure that dollars spent beyond the MBS benchmark would be excluded in any future changes to the financing of this project. The applicant is not proposing to add inpatient capacity to the planning region and will commit to decommissioning beds located in outdated space to offset the increased physical capacity the project will create. In order to ensure compliance, the commission included a condition that limits the hospital use of any physical capacity that exceeds its licensure. During the review process, staff noted needed changes in GBMC's charity care policy and forms regarding probable determination of eligibility as a requisite for charity care. Commission staff recommended changes to the hospital's policy, and GBMC submitted an approved revision, which is now in alignment with the standard. For charity care provision, GBMC is in the bottom quartile of all hospitals in the state, as measured by its contribution as a percentage of operating expenses. Thus, the commission included a condition that requires improved performance by the hospital in its charity care provision. GBMC supplied audited financial statements which showed an excess of assets over liability as well as positive net income in 2017 and 2018, which was supplemented by healthy investment income. In addition, philanthropy is expected to play a significant part in financing this project, and the applicant has a successful record of raising financial philanthropic dollars. In the application, the hospital had asked for a rate increase, but HSCRC found it did not qualify at this time. The hospital revised its financial projections and showed that its project was financially feasible without the rate increase. This project is not expected to impact the volume of services provided by other existing healthcare providers, as the project is designed to modernize acute care beds without increasing the number of operational beds. Before I read the 3 conditions to the CON, I want to draw attention to the slide that's on your screen. After the staff report was mailed, the applicant alerted us of a calculation error with the MBS. The calculation error is described on this slide. The difference was an overstatement of $106,001. The staff report will be reposted to the Maryland Healthcare Commission website and reflect that change. Condition 1. Any future changes relating to this project that result in adjustment in rates set by the HSCRC shall exclude $8,345,327, which is the estimated new construction cost that exceeds the MBS guideline, and portions of the contingency allowance and inflation allowance that are based on the excess construction cost. Condition 2. Prior to its request for first approval, GBMC shall provide information that details the activities it has undertaken following the approval of this CON application to increase the amount of charity care provided to its patients, and will demonstrate progress toward achieving a level of charity care that places it in at least the third quartile among all Maryland hospitals. If staff concludes that GBMC's demonstration of progress is not satisfactory, further action regarding this CON may be considered by the commission at a public meeting before staff issues first approval. Condition 3, prior to its request for first approval, GBMC will outline a plan phased modernization of its nursing units that will identify the bed capacity it will retain in operational status, the physical bed capacity it will repurpose but retain as physical bed capacity, and the physical bed capacity it will eliminate. This plan should specifically address GBM's assessment of the need for surge bed capacity and GBMC's plan to maintain and deploy adequate surge bed capacity when needed. Staff concludes that GBMC's application for a CON to modernize its current facility meets the general CON criteria as well as the specific standards in the State Health Plan chapter governing acute care hospital services. This project is needed, is viable, and will not have an adverse impact on other providers. Therefore, staff recommends that the commission approve this project. Representatives from GBMC are in attendance virtually at the commission meeting today. Tom Dane, counsel, Lori Beyer, chief financial officer, Joshua Campbell, executive director, budget and reimbursement, Stacy McGreevy, vice president, support services, Amber Olig, senior director of corporate strategy, Russ Sadler, manager of capital resources, and Jeannie Lang-Ledig, corporate controller.
Thank you, Jean Marie. Do we have a motion to grant the certificate of need?
I'll make that motion, Andy. Chip Jordan.
Thank you. Do we have a second?
This is Wang, seconded.
Second, I think, was Commissioner O'Connor. Is that right?
Yeah.
All right. Discussion. Any comments?
This is Commissioner O'Grady. I just had a question. The staff had a concern about the charity care provisions or the charity care track record, and I was just wondering, and I certainly applaud their moves to improve that. I was just wondering what our follow-up plan was, what our ability to ensure that these promises actually occur.
So over the course of reviewing the application, we were able to make changes. The hospital was using a universal form, and that form had information on it, social security number, residency status. It also included detailed information about assets, as well as an attestation at the end. So we were able to help the hospital to simplify that form, as well as make some changes in the policy that should allow GBMC going forward to have more ease when people are coming to apply for charity care with the new forms and the new policy. So we're hopeful that that will help to assist with their charity care provision going forward.
And do we have any infrastructure within the hospital to kind of navigate the barriers for low-income people who might need charity care? Do we have that kind of social work or sort of payment advisory sort of panel to make sure that it does actually have some teeth to it?
Would GBMC like to comment on that?
Yeah, so this is Lori Beyer, I'm the CFO. And first, I want to just thank you all for having this August meeting. So I know this is sort of out of the ordinary, but just want to let you know that GBMC is committed to taking care of, the patients in our community. We have revised our policy so that maybe we're not as stringent with application, et cetera. We've put some steps in place to increase access to charity care. As a matter of fact, when you look at our fiscal 20 numbers, we've actually increased the percentage of charity care from the 0.3% of operating expenses to the 0.43%, moving in the right direction. But I also want to make a comment that GBMC has been investing in advanced primary care in the community for 10 plus years, which really does not get factored into the charity care policy. In addition to that, GBMC has a presence in Baltimore City. We are providing primary care to the Helping Up mission. I'm not sure you all know that, but we are actually very invested in Baltimore City. And in addition to that, we took over a hospice program, the Joseph Ritchie program down near Maryland General. So that's just an indication that even though you're just focusing on the charity care, GBMC has done so many things to really help those in need. So we're accepting the recommendation that we will get to that third quartile, but we are doing so many other things to meet the needs of our community and the community outside of Baltimore County.
Good. And good luck with
Commissioner
your.
Bhandari, can you please tell me in dollar and cents what was that 0.3 was and what that 0.43 will be approximately?
So in the application, the percentage is 0.33% of our operating expenses. We're currently at the 0.43%, and we're well on our way to getting to the target of the 0.57%.
What was the dollar amount?
Dollar amount, so we're going from 1.6 million to 2.2 million.
Thank you.
Is there any other discussion? We have a motion on the table to grant the certificate of need. All in favor?
Aye.
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 Any opposed? Hearing none, congratulations. The certificate of need for Greater Baltimore Medical Center in Baltimore County is hereby approved. I will now recuse myself on agenda item number 4, and Vice Chairman Sargent will chair this action. Vice Chair Sargent.
Thank you. Good afternoon. Agenda item 4 is a certificate of need for the University of Maryland Medical Center in Baltimore City, a capital expenditure of $194.4 million for a building addition that replaces and consolidates services of the Greenbaum Cancer Center and adds bed capacity. The University of Maryland Medical Center proposes to construct a 9-story addition above the main hospital entrance to accommodate significant program growth and consolidate oncology services that are currently dispersed throughout the program manager and CON analyst Bill Chan will present the staff recommendation. Bill, please go ahead.
Thank you, Commissioner Sargent and Commissioners. Good afternoon. The University of Maryland Medical Center's Marlene and Stuart Greenbaum Comprehensive Cancer Center is comprised of diagnostic and treatment services dispersed among 10 different spaces in 4 buildings. This project would consolidate these services on 4 floors of a 9-story addition constructed above the main hospital entrance. The addition would consist of approximately 155,000 square feet of new construction and about 73,000 square feet in renovations. The estimated project cost is approximately $194.4 million and is expected to be completed by the fall of 2024. The 9-story addition will consist of a 2-story entrance, shelf space on the 3rd and 4th floors, the relocated cancer programs on floors 5 through 8, and administrative space on the 9th floor, and include renovations to the lobby and 5th floor of the existing hospital and connecting the new addition to the existing hospital on floors 3 through 9. The project will replace 52 beds currently dedicated to oncology patients and add 10 more for a total of 62 oncology beds and 3 nursing units. 52 vacated beds will remain as licensed beds, although the hospital does not have immediate plans for their use. Even with the addition of these 62 beds, the hospital's physical capacity would still be under its fiscal year 2020 licensed bed capacity. The need for the project is based on increased demand primarily for outpatient care. The number of outpatient visits to the cancer center increased significantly by about 35% from 2010 to 2019. It's projected to increase over 28% by the year 2026. While inpatient utilization has decreased across the state and the nation, the applicant's project demand for inpatient oncology services will increase by over 19%, even as statewide demand decreases by 7.5%. In assessing viability, the University of Maryland plans to fund the project with $95.8 million in grants from the state of Maryland, $78.5 million in taxable bonds, $20 million in philanthropic donations, and $100,000 in cash. In response to state's request for an opinion regarding financial feasibility, the Health Services Cost Review Commission reviewed key financial projections, ratios, and indicators, and stated that the University of Maryland medical system exhibits profitability, liquidity, and capital resources that are sufficient to maintain its credit ratings. HSCRC staff stated its belief that with proper management, the proposed project is financially feasible. As for impact, the increased capacity planned for the blood and marrow transplant service is not expected to have a negative impact on existing providers in Maryland. While the cancer program will receive a slightly larger share of inpatient medical oncology volumes, the existing oncology providers will experience a minimal decrease in discharges that is equally distributed. In summary, the project complies with applicable standards in the acute care hospital services chapter of the state health plan, has demonstrated its most cost-effective approach, is viable, and will not have an impact on existing oncology providers in Maryland. In response to the shell space standard in the state health plan, since the hospital may submit to HSCRC an application for an adjustment in reimbursement rates in the future, staff recommends conditions which are standard for hospital projects that include shell space. Therefore, staff recommends that the commission approve this project following conditions. Condition 1, requiring the University of Maryland Medical Center to submit an assessment of the need for surge bed capacity at the facility and its plan to maintain and deploy adequate surge bed capacity when needed. Condition 2, stating that any future change to the financing of this project involving adjustments in revenue must exclude $2,210,850 in shell space related costs. Condition 3, stating that the applicant will not finish the shell space without obtaining all required commission approvals and will not request any adjustment in budgeted revenue by HSCRC that includes depreciation or interest costs associated with construction of the shell space, unless it has obtained either CON approval or determination of coverage that the CON is not required. And condition 4, stating that in making any future adjustment to budgeted revenues related to the cost of this project, HSCRC shall exclude the capital costs associated with the shell space until the space is finished to use for regulated activity. And in calculating any revenue adjustment, the capital costs associated with the shell space should only account for depreciation and interest expenses going forward for the remaining useful life of the space. We have several individuals representing the hospital who are on the line. I'd like to introduce them. First is Todd Lane, counsel. Ms. Allison Brown, interim president of the University of Maryland Medical Center downtown campus. Ms. Suzanne Calpurthwaite, director of nursing. Brett Elam, project manager. Dana Farrakhan, senior vice president, strategy, community, and business development. Georgia Harrington, senior vice president, operations. Joseph Hoffman, senior vice president, chief financial officer. Scott Tinsley Hall, director, strategy, system market intelligence. Stanley Whitby, vice president, cancer services, and Ms. Linda Whitmore, director for project development. That concludes my presentation.
Thank you, Bill. Before we move into the discussion, do we have a motion to grant the certificate of need?
Commissioner Bandari.
So moved.
I heard Commissioner Bandari move, and I heard a second. Was that Commissioner Reimer?
Motion. Commissioner Boyle.
Thank you, Commissioner Boyer. With that said, is there any discussion?
Randy, this is Chip. Could I ask an observation?
Go right ahead.
And especially to my friend Allison of many years. I'm all for this. I think it's great. The only thing, and we've always had this issue about having bed capacity. And I remember a few months ago, the university came forward, and one of the issues was, and we approved them to expand their psychiatric capacity. And I would just suggest maybe that as they look at those empty spaces, and if the need still exists, you know, in Baltimore City, in either that area or others, that serious consideration, you know, just might be given by the university to how they might meet another void, since they have sort of some space there that's not being used these days. It's just a comment. I don't need a response or anything, but just a thought. Thank you.
Commissioner, are there any other discussions or questions?
Dear Sergeant, I just want to say, you know, University of Maryland Cancer Center, they do a wonderful job. They take care of everybody, whether a patient is insured or uninsured. I'm working with them for a long time. I really appreciate all their help in the community, and they are doing a great job.
Thank you. Is there any other discussion? It looks like then, in that case, we can call the question. Are all in favor? Say aye.
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 Are there any opposed? Congratulations, the motion passes. The certificate need is hereby approved. And we can bring back Chairman Powell.
I'm back. All right. Thank you, Vice Chairman Sargent. On to agenda item number 5, an update on the redesign of the Healthcare Quality Reports consumer website. The Center for Quality Measurement and Reporting is responsible for the Commission's healthcare facility quality and performance evaluation mandates to increase transparency and informed decision-making among consumers and to facilitate improvements in delivery of care. Teresa, Director of the Center, will provide an update on staff efforts to modernize and redesign our primary consumer website, the Maryland Healthcare Quality Reports. Teresa?
Thank you, Chairman Pollack. Good afternoon, Commissioners. Over the past several months, the quality team has been working very hard to totally redesign our main consumer website, the Maryland Healthcare Quality Reports. And today what I'd like to do is to provide a high-level overview of that initiative, so it provides some context for what we're doing, to talk a little bit about what's involved in quality reporting, what our current site looks like, to preview the new site, and prepare you for next month, where we plan to come back with a test site, during which time we can demonstrate the functionality and the new visual aspects of the site. Next slide. So I'd like to briefly introduce the quality team and the staff that are associated with this project. Again, just an overview of the mandates that are associated with our public reporting initiative, describe components of quality reporting, talk a little bit about how we've consolidated these individual mandates into one, and then preview the new quality reports consumer site. Next slide, please. So our quality team is comprised of 6 staff, 2 persons focused on hospitals. That's Courtney Carta and Sumitra McCammon. Stacy Howe and Julie Deppy focus on our long-term care and health plan divisions. And our newest area, Mariama Gondo heads up, and that's the hospital outpatient and ambulatory surgery division. And of course, our contractor and partner, Advanta Government Services, LLC, actually, supports this work. And Karen Smith is the project director. Raina Quinn is the program manager. And there are quite a few other staff who work with the contractor to make this work successful. Next slide, please. this slide just to reiterate how providing information to consumers is a key component to our mission, not only to enable consumers to compare and evaluate providers, but also to facilitate improvement. Next slide, please. So in terms of our mandated quality reporting initiatives, we are required to report on commercial health benefit plans. There are about 6 HMOs and 4 PPOs now. In terms of long-term care providers, nursing homes are identified in the law. We provide information on nursing homes, but we also provide information on the assisted living facilities, those with 10 or more beds, hospice providers, home health providers, and adult medical daycare. And of course, we are required to report on hospital inpatient and outpatient services, as well as ambulatory surgery centers. Next slide, please. This actually comprises about over 1,000 healthcare providers across the state whose data are included in this reporting activity. In terms of the components of quality reporting, of course, measures data collection is a component, but I wanted to highlight here that we do download quality metrics for not only hospitals, for nursing homes, hospice, and for other provider areas. But our website includes quite a bit more than just the federal measures that are provided on other sites as well, such as Hospital Compare, Nursing Home Compare, and I believe Hospice Compare. For our hospitals, we also report on infections. We report patient safety indicators, inpatient quality indicators, maternal and child health measures are provided. Of course, from our all-payer database, we provide on the number of cases, the average length of stay, and the average charge per case for all medical conditions treated in Maryland hospitals by the APR DRGs. For nursing homes, we also utilize data collected by Paul Parker's shop, the long-term care survey, as well as the hospice survey, which supports quite a bit of the information that's available for nursing homes, assisted living facilities, and other long-term care providers. Home health inspections and complaints are reported using OHCQ information. We do our own flu survey for nursing homes, as well as assisted living facilities. And we administer a freestanding ambulatory surgery facility survey, which enables us to report on the outpatient providers and types of cases provided, specialties, and locations on the website. Data validation is a strong component and has been since we began this work. We have access to infection preventionists who have provided data validation and audits for us, looking at the data before it's reported to consumers. We have audited our cardiac data sets that are used to support some of the work in Paul's shop as well. And we have plans to look again at inpatient case mix data to see if the reporting of social determinants of health in terms of ICD-9 coding, if that's done correctly. So some of the plans that we have. Of course, consumer engagement is a major component, not just with our formal focus groups, but staff take calls all the time. We're able to understand what consumers are looking for. We understand how difficult our website can be to navigate. So we learn quite a bit from that. We're strengthening our data analysis component so that we can add additional information on health disparities. And of course, we, through our work, we're able to work with Leapfrog to add or to include Maryland hospitals in their hospital grading system. Ongoing communication, promotion, and outreach is a key component. And you may recall we put together an introductory video to help consumers understand the site. We have been out to conferences and to fairs and other events to try to spread the word. There's quite a bit of social media posting that the staff does to kind of keep the word, or at least to increase public awareness of the site. Absolutely more to be done, but we're working on that. In terms of maintaining and strengthening relationships with stakeholders and providers, HSCRC we work closely with. We are working with them in their effort to report to CMS on the total cost of care progress, looking in addition to hospitals at other provider settings. Our staff, Stacy Howes, is working with the HSCRC on their grant program to get hospitals to work more closely with long-term care facilities in responding to COVID and infection prevention kinds of activities. And of course, as we spoke a few months ago, we are working with the Maryland Cardiac Surgery Quality Improvement Initiative to share some of the data we have from both the hospital database, the charges that are there, and matching those cases so that they can append the data to their STS data set, the Society for Thoracic Surgery data set. Next slide, please. So I guess it's about 6 years ago, we did our last redesign of the site. And at that time, each of the individual sites were reported separately. They were separate mandates. Our health plan report was a PDF report. And we decided at that time to bring all of those reporting requirements together. And it was in line with changes that had occurred within our organization when our executive director restructured the organization to move centers from provider specific to sort of more functional. So instead of having a hospital center and a long-term care center, we now have the quality reporting center, and then there is the health plan, health facilities planning and development division. So with that, we began to think more broadly and tried to pull together all the reporting requirements into one space. And that's when we created the Maryland Healthcare Quality Reports website. And on the front end, it looks as if all of these reporting requirements or guides were under one umbrella, but actually we didn't have the resources to truly redesign everything. So the front end looks the same, but the long-term care and our outpatient guide still remain on separate websites and still require redesign. And that's where we are now, is to really fully integrate website and the mandates so that when a consumer uses a website, once they know how to navigate for any provider type, it's the same process across all provider types. We've also improved the visual appeal and the functionality of the site, and we made sure that it aligns with state website requirements. As I'll show you in a minute, we've also added a health disparities section so that we begin to focus on health disparities. We do have, as Ben mentioned earlier, we've been given the opportunity to fill one of our vacancies, and one of the primary responsibilities of that position will be to help us build that section of our website and collaborating with the other staff who will also be looking in their respective provider types for how we can address health disparities. So the first phase of this work is focused on long-term care providers, specifically nursing homes. If you could go to the next slide, please. So this is a screenshot of the current website. Again, it appears as if all the provider types are uniform, and one would assume that they function similarly, but really on the back end, the surgical, says surgery centers, that's an existing website that takes you to our outpatient site that is pretty old, and that's part of this redesign that we're working on. And we hope to enhance that site from just having provider, like an inventory of providers, their locations, their specialties, and case counts, to having even more information to include outpatient charges, for hospital-based outpatient charges right now, which is what we have available to us. So we're working on that. The health plan guide was, as I said earlier, was modified from a PDF report to a web-based presentation. And then our long-term care guide, which is our most popular site, we did not redesign, but we were able to overlay the site with some quick compares from free software that we were able to utilize from ARC. So we go to the next slide, please. So this is just the second level of the web page that takes you to long-term care information. So you'll see on the left, there is a page that lists a number of options for viewing comparative information. And then to the right, it's a picture of the existing long-term care site that has a wealth of information beyond just the measures, but also educational type information, planning for the aging process, paying for long-term care, options for remaining at home and alternatives, those kinds of things. Next slide, please. So this is our new site. This is the home page. And you'll see again, it's much brighter. The ideal here is that if you look down to the icons in the white space, you can go directly to a provider type if you're interested in assisted living or hospitals or hospice. You can use that feature to get to it, or you can type in a word that you're interested in. So for example, from our focus groups, we found that individuals are interested in reviews of nursing homes. So if reviews, you'll be able to get to our family experience of care information. So it actually brings it up a bit more. So you can find information on the cleanliness, the staffing, services provided. Those kinds of things will be more readily available than coming to the site and not really knowing what else is available on it. So that's one aspect that I think should help with the ease, the usability of it. You'll also see here just under the white bar that says, what are you looking for? Popular services. Price information was commonly cited as something consumers were interested in. And of course, we don't have exactly what they want because they want out-of-pocket costs, what it will cost them. But what we can provide to consumers are rates for assisted living facilities, daily room rates, adult medical care daily rates. We'll have volume, as I said earlier, volume and average charge information from hospitals for all medical conditions. And then there'll be for nursing homes, private pay room rates that can be made available if persons are interested. In the upper, you see in the black bar, we have COVID, learn more about COVID in Maryland. That's to make sure that we have an opportunity for persons to go here. You can go directly to the, it links directly to the Maryland site to provide by nursing home number of COVID cases for both residents and for staff. So that information will be available. The health disparity section in the upper left will be there. Additional resources. We'll have this available in multiple languages. You'll see that more to the right. And in terms of about us, we want to develop a bit more information on how we describe what we do and why we do, and we'll be bringing back ideas for that section as well. And then of course, you'll see down in the lower right-hand corner, there's a little chat box. And next month, the team will present how those things will function and give a demonstration of that. So if I'll just pause for a minute here to see if there are any questions before I go to the final slide.
This is Commissioner Sargent. I do have a question.
Mm-hmm.
So how are we approaching mobile devices? Because a lot of these pieces of information, I would probably be looking up the adult daycare or the nursing home information while touring the adult daycare facility or the nursing home. I tend to go to Best Buy and shop Amazon while I'm in Best Buy.
Right.
People are increasingly going to use the 4-inch screen on their phone for this kind of stuff.
It's adaptable. It's built for to be accessible on your phone as well.
Okay, so it scales. It's equally accessible on both.
Yep.
Good, thank you.
And I know I've kind of rushed through it, but next month we hope to come back if the agenda permits and actually demonstrate the site. At least the nursing home and long-term care area. That's our primary focus first, and then we're going to move on to the outpatient and the hospitals.
I have a question. This is Commissioner Thomas. I like your color palette. I mean, I think this redesign is great. I'm going to ask a question about what you have at the bottom. When we build these kinds of infrastructures, and it happens to be under the current administration, who knows 10 years from now? I guess my point is, can we assume that what we're building now lives beyond any one administration?
Yes, definitely.
Okay, that's all I needed to know. There's a lot of investment and time and effort. It's central to what our state needs.
Right.
And we build off, every contribution that each administration makes, but I think that's important. But because we have that at the bottom, and I don't know if that's on the bottom of every single commission slide deck in terms of official websites, but nonetheless, I want to make sure that what we're building lives beyond any one administration.
Yes, it does. And we've replaced, we had O'Malley's picture in the past, and we just replace it as new administrations come on board.
Okay, I'm just highly sensitive lately.
Teresa, hi, this is Commissioner O'Connor. Just one quick question. Under the category physician, I am looking for information on, what do you have under physician? What information is there?
Right now, for physicians, we go to the office of, I'm blanking on it, our, both to Physician Compare and to our own state office on,
Board of Physicians.
Yes, thank you, Board of Physicians, yes.
Okay.
So we don't have a
so
data
there's
collection. No, right.
There's no data on so-called cost of the physician, whatever.
No,
cost
not at
of
all.
services, because that pretty much is all standardized. I've had that question before about GBR money and how much a procedure costs in one hospital versus another. It has nothing to do with the real cost of the procedure. It has to do with just dividing GBR money by the number of cases you do. So
right.
The public is a little bit misled on the cost, I think.
Right. I think for the physician, because we're really more of information and referral in that regard. So we do link there because we don't have anything yet. But and we have it on our current site too. We link to the to, you can look up physicians and see where they're what hospitals they're affiliated with and some other useful information.
Okay. Thank you.
Other comments?
This is Commissioner Boyer.
Go ahead.
I love the way that the site looks. I just want to, once it all gets established, I want to encourage us to think of more creative ways to let people know about this incredible amount of information that's available. While social media is a great way of sending it out, it too can be limiting. And once our world opens up again, I know that the local health departments do have booths at different community events. I don't know if it's possible to also send them information for those booths so that they can help distribute this information.
I believe so. We try to reach out to the health department with the health department and some of the work we do at the conferences or conventions or fairs are in collaboration with the health department. So we do that, and we do try to find alternative ways to get the word out. And we know that, and the next slide talks about next steps, but that's really what it's about. Once we get this together, everyone likes it, then we really need to do another push for promoting it and making sure that people are aware of it.
Absolutely, it looks great. Good job to everybody.
Well, thank you. And in the interest of time, I think the final slide is, I don't need to go through it. I've kind of touched on most of the things when we were going through the presentation.
This
So
is
if-
Commissioner Bandari. You know, there are 47,000 providers for Board of Physicians and more for the nursing board also. You know, we used to send this information in the newsletter to all the providers so they can disseminate information to the patients and other providers also. That's something to look at.
Oh, perfect. Thank you. That's a great idea.
If you need any help, I can facilitate that on the board side.
Okay. I'll reach out to you. Thank you very much.
Thank
Dr.
you.
Other comments?
So hopefully we'll see you in September.
Yes, thank you, Teresa.
Mhm.
Thank you.
All right. Agenda item number 6, update on the development of the third track of the Maryland Primary Care Program. So CMMI, the Centers for Medicare and Medicaid Innovations, has requested that the Maryland Primary Care Program submit recommendations on a proposed track 3 for the primary care first model to be the framework for, and that the primary care first model should be the framework for track 3. The MDPCP Advisory Council convened a Track 3 Recommendations Committee to develop draft program requirements document for review by CMMI and discussion by the Advisory Council. David Sharp, the Director of the Center for Health Information Technology and Innovative Care Delivery, will update the Commission on the primary care first and committee discussion items. David?
Thank you, Mr. Chairman. Okay, so good afternoon, Commissioners. It's my pleasure to provide you with an update on the Maryland Primary Care Program activities relating to developing an optional Track 3 for practices in the MDPCP. Next slide. As a reminder, the MDPCP is one of 3 programs in the total cost of care model. The model includes the Hospital Payment Program, which tests population-based payments for Maryland hospitals, the Care Redesign Program, which allows hospitals to make incentive payments for non-hospital healthcare providers that perform healthcare redesign activities aimed at improving quality of care, and the MDPCP program, which supports and incentivizes primary care providers in the transformation to advanced primary care. As of January 2020, there are 352 practices in Track 1 and 124 practices in Track 2. Track 1 and Track 2 practices must indicate their capability to deliver the 5 comprehensive primary care functions at the time they submit an application. They include access and continuity, care management, comprehensiveness and coordination, beneficiary caregiver experience, and planned care for health outcomes. Track 2 practices must also have advanced health IT capabilities and the ability to provide greater depth and scope of care than Track 1 practices. In early 2019, the Secretary of the Maryland Department of Health requested that an advisory council be established to serve in a consultative and advisory role to the Secretary and the MDPCP Program Management Office. The advisory council was formed in the spring and has convened periodically since October of last year. Next slide, please. The MDPCP program mirrors CPC Plus, a national advanced primary care model that aims to strengthen primary care through payment reform and care delivery transformation. CPC Plus is in 18 regions and has about 2,800 participating practices. CMMI released the second annual evaluation report of CPC Plus on July 16th. The evaluators noted that participating practices made meaningful changes to care delivery during the first 2 years, and that practices have more work to do in the remaining 3 years to further improve the quality of care they provide. They also indicated that additional support would help them to do so, and that it's too early to draw conclusions about the likely longer-term effects of CPC Plus. The MDPCP program is an investment in primary care, which could generate costs to Medicare in the short term that may negatively impact the total cost of care savings. CMMI is encouraging increased practice accountability through a Track 3 model that is built upon the primary care first framework. Next slide, please. The MDPCP Program Management Office asked the Advisory Council to formulate draft recommendations for Track 3 by late summer. The Advisory Council convened a committee that developed a framework for deliberation by the Advisory Council and reaction by CMMI. The Advisory Council met just this Tuesday to discuss the framework and CMMI's feedback. Next slide, please. Primary Care First is a voluntary risk-based payment model intended to reduce Medicare spending by preventing avoidable inpatient hospital admissions and improve quality and access to care for beneficiaries, particularly those with complex chronic conditions and serious illness. Next slide. Thank you. Primary Care First will provide participating practices with a prospective professional population-based payment, which can range from $28 to $175 per beneficiary per month. Practices will also receive a $40.82 flat payment on select evaluation and management services. To encourage practices to provide continuous care to attributed patients, the population-based payment is adjusted for patients that seek care outside of the practice. Primary Care First includes a performance-based adjustment that ranges from negative 10% to a positive 50% of total primary care payments. In year one, adjustments are determined based on a practice's acute hospital utilization alone. In years 2 through 5, adjustments are based on practice acute hospital utilization performance of the nation and local region. In performance year 3 and beyond, practices must exceed a quality gateway in the previous performance year to avoid an automatic minus 10% adjustment for all 4 quarters, regardless of their acute hospital utilization performance. Quality gateway metric will be made available to practices in the program at the beginning of each year. There's also a continuous improvement bonus that rewards a practice's individual performance improvement on acute hospital utilization. The practice's acute hospital utilization performance is based on its own performance in the preceding 4 quarters. Continuous improvement bonus payments range from 3.5% to 16% based on a practice improvements target. There is also a seriously ill population option. CMS will use durable medical equipment claims data to identify beneficiaries that have significant chronic or other serious illnesses. Practices will receive a one-time $325 payment for a first visit and a monthly $275 per beneficiary payment and a flat office visit fee of $50. There's also a $50 on the monthly beneficiary payment. Practices have an opportunity to earn back this payment and an additional $50 quality bonus based on achieving performance targets. Next slide. Primary Care First application and onboarding of practices is shown in the slide. The program is set to launch in 26 regions in January of 2021. Next slide, please. Next slide, please. Thank you. The committee identified elements of the Primary Care First in 6 categories for consideration by the Advisory Council. I will briefly highlight that. Category 1, titled Payments, includes 6 items. The first one, for discussion by the Advisory Council, was to base population-based payments on individual health scores rather than a practice's average score. Next, providers should receive a fixed payment for each patient encountered using the current Medicare fee schedule as opposed to the 2018 fee schedule used in Primary Care First. Financial adjustments should be based on national and regional comparisons in Primary Care First were not adequate in Maryland model due to the program variations between Primary Care First and MDPCP. Determine regional and hospital utilization performance using existing MDPCP quality measures, which are aligned with the Maryland State Health Improvement Strategy as opposed to those included in Primary Care First. Eliminate acute hospital utilization adjustment and replace the seriously ill population program with the existing MDPCP complex tier 5, which exists to address patients that have complex needs. Next slide, please. In category 2, substitute the acute hospital utilization measure in primary care first with the MDPCP hospital and emergency department utilization measure. Include in the quality gateway patient experience and comprehensiveness of care survey tool and clinical quality measures that were largely agreed upon by the state and CMMI previously. In category 3, allow practices to develop their own approaches to care delivery rather than being required to meet specific care delivery requirements. And lastly, in this category, require practices to report on progress to CMS and the state. Next slide, please. Category 4, align eligibility with MDPCP and include co-located psychiatry and obstetrician and gynecologist as provider types in the program. In track 3, practices need to have experience in track 2. New MDPCP applicants will need to meet certain primary care first eligibility requirements and have track 2 experience. Allow federally qualified health centers to participate in track 3. Unlike in the current Maryland in the primary care first model, FQHCs are not included in the program. CMS and the state will encourage other payers to align payment, quality measurement, and data sharing in support of MDPCP practices. Require practices to participate for a minimum of 5 years, which is different than primary care first, which participation requirements are up to 5 years. In the category 5, the seriously ill population, adjust care delivery to match the MDPCP tier 5, which is for complex patient, as a substitute for the seriously ill population program. And lastly, in category 6, rely on CRISP to provide analytics information via the CRISP dashboard. Next slide, please. So where do we go from here? Next steps, the advisory council is currently working on addressing CMMI comments and reviewing the draft construct that was submitted for feedback by the committee just earlier in the month. The advisory council is anticipated to meet weekly over the next several weeks to finalize the draft version for review by CMMI. Throughout the first 6 months of 2021, the MDPCP Program Management Office, with advisory council guidance and input, will negotiate with CMMI on track 3 requirements. We realize there's a lot of activity that's going on with this program, and staff plans to keep the commission updated on the progress of the negotiations. Next slide. This final slide gives you a glimpse of the activities that have occurred thus far, shown with the green check mark in the box, and dates that and activities that are on the horizon. We suspect that the dates will shift as the council continues to work on the draft framework. So that concludes a rather high-level overview of MDPCP activities related to track 3, with some parallel references to what primary care first looks like for benefit. So with that, I'll conclude, and if there are any questions, I'm happy to address them.
I have a question.
Go ahead.
Commissioner Sargent, looking at this, it looks like there's about 124 track 2 practices. So how many do we really think are going to take advantage of track 3? And out of those practices, what portion of the population would they cover? I mean, are we talking the 25 huge practices would cover a significant portion of the state? What do we estimate the difference that track 3 would actually make, assuming that it works out?
Thank you for that question. Let me try to back into it in pieces. Today, the entire state is represented by the practices that are participating in the program. In track 1, which has a small percentage today, about 124 practices, there is a set, the requirement in the MDPCP program is by year 3 of their participation, they would move into track 2. And there's a request by CMMI that track 1 eventually be eliminated as an option for any practice to move into it. We have heard interest already expressed from some of the larger practices that if a if a track 3 program is developed, they would likely look forward to moving from track 2 into track 3. There is a sense which is being discussed, will be discussed by the advisory council in looking at more of a progression pathway to move track 2 to track 3, which is where we feel that CMMI ultimately would like to see practices end up.
So David, if I could, how many so we have about 900,000 Medicare beneficiaries in the state. How many are attributed to MD-PCP practices?
So the exact number, we're approximately in the, I want to say almost 400,000, just about 400,000, maybe off a little bit.
So keep in mind that most of the practices are track 1. Track 1 was a temporary track that was moving practices onto this advanced care, primary care model. That is a track that CMS has said should transition away over the next period of time, a year to 2. Practices, when they joined, understood they could only be in track 1 for up to 3 years. So that's an expectation that is there. I think the question, there's a number of questions. David did a great job of going through this really quickly, but there are key questions that the broadly the advisory council and the state will have to answer. And I think the central one is how closely will the track 3 program mirror the primary care first program that is slated to launch in January. Keep in mind, as we said at the outset, that MD-PCP itself is modeled after a federal program, CPC Plus. That program really evolved in the last several years of the Obama administration, got underway in the early first year or 2 of the Trump administration, but never really was fully endorsed by the political leadership at CMS. Now we know primary care first is really a Seema Verna and her senior team model. We'll have to see over the coming months how quickly primary care first percolates across the 26 within the 26 regions, and then how much of those program elements are taken into the track 3 of the Maryland primary care program, so that we can launch a program somewhat to a great degree alike primary care first, likely in 2023, but potentially as early as 2022. The key element,
go ahead, Ben.
The key element that we have in Maryland that has posed a lot of challenges is that we have a total cost of care model built on the chassis of hospital global budgets, and the dollars and cents accounting that go on with primary care first, or excuse me, go on with the Care Plus program and the Maryland primary care program, is that much of the savings that would accrue to a primary care initiative in the best of possible worlds are absorbed by the GBR already. And so the primary goal is to make sure that whatever primary care initiative that we launch is very tightly coupled with the overall total cost of care initiative. And we're fairly measuring whether that program contributes or does not contribute to the broader overarching model here in Maryland. Dr. Pollack?
Any other comments?
This is Michael Grady.
Is there any cost sharing? So how the primary care, because obviously, primary care is evolving. It takes a lot of time and effort on part of primary care physician, which I have full sympathy for that. Sharing or how does the payment model works?
So there are a couple ways to address this. So the risk is you have an upside risk of approximate of 50% and a downside risk of minus 10%. And within that broad range, there are a couple ways that it's broken apart. There's percentage. There's about 16% for what's called a year-over-year continuous improvement that has 7 groupings, and based upon the practices meeting targets that are set each year for them on a year-over-year basis, it would determine the percentage of that 16%. On the -10 and on the plus the 34, that's percent on certain goals that relate to quality. And that's you have to have a certain quality score, and then there's also on performance too, on a series of utilization, like 5 measures of HEDIS measures that you have to achieve a certain score. So there are a couple different ways that the total payment is broke out, but it's risk-based by and large.
Commissioner O'Grady, I think you're next.
That's okay.
Okay. David, who's driving the development of this on our side? Is that Dr. Haft?
Mr. Chairman, Dr. Haft has made the request PMO of the advisory council, and the co-chairs are myself and Dr. Michael Riedman, and then of course the council members. And if you recall, you may recall that the council members, staff provided nominations to the commission, and the commission approves those nominations, and that occurred last spring actually.
So the council negotiates with CMMI?
Council provides feedback to the PMO, and the PMO ultimately has the role of negotiating. They will be using guidance with the guidance from the advisory council.
Got it.
Dr. Pollack, this is Dr. Bhandari. Dr. Riemann is a very good qualified primary care physician. I really appreciate you have the right person on the team.
Thank you. All right. Are there any other questions about this? Very good. Thanks, everyone. Thank you, David.
Sorry.
Agenda item number 7 will be the overview of upcoming activities. Ben, would you like to share the upcoming activities for September's public meeting?
So thank you. And again, thank you, commissioners, for attending today. We will have one additional drug treatment program that we will bring before the commission. This is an inpatient withdrawal management and acute rehab program in Baltimore City that we hope to bring to the commission. We will likely update the commissioners on the progress we've made in changes to the state health plan chapter over the summer, as well as begin to explain to you some of the changes we anticipate making in the data regulations pertaining to release of information from the all-payer claim database. Here in Maryland, it's called the Medical Care Database. You've heard from Teresa that a fuller description of the update to our performance reporting system will be on the agenda. And I would anticipate that we would have some information just on operations and budget for the Healthcare Commission as that unfolds in anticipation of the session. David, we'll keep David, my foot on him. And I think we are, Dr. Pollack gently pointed out that although we are supporting the launch of the primary care, the next phase of the primary care program, it's a little unclear how much control the commission has over it. This is something that the state is negotiating with CMS, and we would anticipate that this is going to take a lot of work. Track 3 is ambitious. Track 3 anticipate that practices are highly organized. I anticipated that Dr. O'Grady would say highly consolidated, and that's not really a lot of care environments like here in Maryland today. So this is going to be a big lift if we are going to bring it into full alignment with the total cost of care.
Excellent. Thank you, Ben. And thanks again to staff for all the work in putting together this agenda and this meeting for the first and hopefully last August meeting of the commission. But with any luck, we'll be back on track next year, and we won't have to, we'll be able to meet in public at some point or in person. Agenda item number 8 is a motion to adjourn. Do I have a motion?
So moved. Second from Commissioner Thomas.
All in favor?
Aye.
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 Thank you, everyone.
Thank you, everybody.
Thank you all.
Enjoy the rest of your summer.
Bye-bye.